Hi there, it's Tatiana. I am a doula. I am here again to read the handouts from the Lactation Counselor training course. So today I'm going to be reading handout, the 1B handout. Milk composition is complex. Each species of mammal milk is different. Milk is species specific. Mammal species with high fat or protein and low water content milk have infrequent feeds. Mammal species with higher water content milk have more frequent feeds. All mammal milk contains lactose, even hedgehogs. Group 1 is a nest or cache. Group 2, carry, follow, hibernate. The most rapidly developing organ in human newborns is the brain. Human milk is the ideal fuel for brain growth. The nursing pattern should be frequent to accommodate this composition. Human milk changes continually. This makes it impossible to obtain a single representative sample of milk. Stages of making human milk. There is a diagram here that I tried to print out. It says the stages of making human milk, the colostrum, secretory differentiation, lactogenesis 1, placental hormones. So, and then the secretory activation, lactogenesis 2, complete delivery of the placenta, rapid drop in progesterone, and then this is the transitional milk between the colostrum and the mature milk. Then full on lactation, so that's lactogenesis 3, it's early in the morning. Galactopaces. Just think of Galact, that will remind you that it's milk. Prolactin from frequent nipple stimulation, frequent removal of milk, and that's the mature milk. Breast milk composition changes over the course of lactation, preterm versus term milk. Preterm milk appears to have different composition for the first 5 to 7 weeks after delivery, independent of gestational age at delivery. In general, preterm milk appears to be higher in protein, fat, and electrolytes than mature milk. However, if the baby is small, SGA, large, LGA, or appropriate, AGA, for gestational age does not seem to make a difference in milk composition. After 1 year of lactation, human milk expressed by mothers who have been lactating for or over a year has significantly increased fat and energy contents compared with milk expressed by women who have been lactating for a shorter time. Kung mothers nursing lasts about 2.5 minutes, 140 minutes per day. The babies are healthy and robust. How do they get hind milk? It turns out that the concept of fore and hind milk, how and when there is the most fat and calories, is a lot more complex than was originally described. In research studies, the milk at the beginning of a feed is called fore milk. The milk from the end of a feed is called hind milk. But as it turns out, fore milk does not mean low fat, although sometimes it may be relatively lower in fat. Hind milk is not always highest in fat. Sometimes fore milk and hind milk have equal amounts of fat. We should not give mothers rules about how long a feeding should last based on ideas of fore and hind milk. There is no truth to the argument that to obtain the most nutritious milk for the infant, the mother should encourage her baby to consume more hind milk. And that's from Cregan and Hartman. Breast milk composition changes over the course of lactation. Within a day, there are diurnal variations in the composition of milk, and then within the feeding. The composition of milk is also changed by the way it is taken. There is no difference in baby's net fat intake according to the number of breasts suckled per feeding or the breastfeeding frequency. The breastfed baby can regulate his fat intake quickly, and thus mothers should be encouraged to practice baby-led feeding. Some babies do better on one breast per feeding. Infants whose mothers produced higher energy milk consume less milk volume compared with infants consuming milk with lower energy densities. Breast milk composition changes over the course of lactation, within the day, within the feeding, between feedings. Maximum fat levels were obtained 30 minutes post-feed. Mothers of male infants seem to produce milk that has a 25% greater energy content than mothers of female infants. Men with high prolactin levels due to brain fog, brain tumors, or drugs make human milk. Milk composition is complex and milk action is redundant. Milk is more than nutrition. Bioavailability of nutrients is higher in human milk than in other foods or supplements. An example, iron. Less diarrhea is the most readily acknowledged advantage of breastfeeding, but exclusive breastfeeding makes the biggest difference in rates and severity. In the U.S., 86% of diarrhea-associated infant deaths occurred among low birth weight, less than 2,500 grams or less than 5.5 pounds infants. Mechanisms by which exclusive breastfeeding protects babies from diarrhea. 1. pH of the gut breastfeed baby's gut is more acidic, while formula guts are more neutral or basic. Gut bacterial colonies, the microbiome of mixed-fed babies, are similar to exclusively formula-fed babies. Low iron in the gut. Relatively low iron content in human milk. Presence of bifidus factor in the milk, which promotes the intestinal presence of lactobacillus bifidus that maintains a low pH and crowd out pathogenic organisms. Presence of hormones, hormone-like factors, and growth factors that stimulate growth and development of the GI tract and GI mobility, such as GI hormones, prolactin, EGF, epidermal growth factor, prostaglandins, antibodies such as SLGA bind to microbiobes in the baby's intestinal tract and prevent them from being absorbed into the rest of the body. Mother's IgA has been found to protect against the development of necrotizing enterocolitis in preterm infants. Maternal IgA shapes the host microbiota relationship of preterm neonates, and that IgA in maternal milk is a critical and necessary factor for the prevention of NEC. White blood cells. Blood cell wall disruptors kill microbiobes by destroying the cell walls. These include fatty acids and lysozymes. B12 binding factor reduces the amount of B12 in the intestines available to microbes. Lactoferrin deprives bacteria of iron, disrupts the integrity of the outer membrane of bacteria, assists in intestinal maturation and in the recovery of the intestine from injury, plus other mechanisms. Antimicrobial activity boosters such as fibronectin and gamma interferon. Mucosal wall protectors such as mucins and oligosaccharides, which also function as food for beneficial bacteria, adhere to microbes, binding them so that they don't attach to the gut wall. Microbes, yes, from the mother's skin and the bacteria in the mother's breast milk seed, the infant gut, underscoring the importance of breastfeeding in the development of the infant gut microbiome. There is translocation of organisms from the mother's intestine into her milk. 13. Absence of exposure to contaminants, bottles, teats, water, and formula ingredients. 14a. When mother is exposed to organisms, she makes antibiotics and secretes them into her milk. 14b. Another way baby is protected, cells from the baby's mouth go into the breast. Antibodies are made in the breast. The process of breastfeeding has effects beyond the components of the milk. Breastfeeding changes both immune systems. 15. Synergistic effect of all these mechanisms and others yet to be discovered. For example, gastrointestinal hormones and breastfeeding. Gastrin and cholecystokinin. I can never pronounce this. Gastrin and cholecystokinin promote glucose-induced insulin release and growth, promoting effects in the gut. Somatostatin inhibits GI secretion, inhibits motility in the GI tract, and the release of the most GI hormones. Also, somatostatin inhibits the secretion of HGH from the pituitary and inhibits cellular growth and proliferation in the gut. It's a whole lot of gobbledygook for me. We can break that down when we're studying. What increases gastrin and decreases somatostatin in babies? So I put a note here that somatostatin is stress. What increases gastrin and decreases somatostatin in babies? Sucking babies have cutaneous touch receptors in their mouths that respond to sucking starting at 27 weeks gestation. Species-owned milk decrease stress, wellness, touch. Adult GI hormones are also impacted by suckling. When the mother suckles, her gastrin and cholecystokinin go up. This increases the efficacy of insulin and increases the storage of ingested nutrients. Pregnancy itself may confer an increased risk for type 2 diabetes in the mother, which breastfeeding can negate. Compared with women who have not had children, childbearing women who do not breastfeed have a 50% increased risk of T2DM in later life. Type 2 diabetes in later life. These notes say T2DM, so you have to just remember that. Weight loss in the breastfeeding neonate. In the first days after birth, most babies lose weight, some from normal diuresis. AAP 2005 said, weight loss in the infant of greater than 7% from birth weight indicates possible breastfeeding problems and requires more intensive evaluation of breastfeeding and possible intervention to correct problems and improve milk production and transfer. AAP 2012 added, evaluate body weight gain. Body weight loss no more than 7% from birth and no further weight loss by day 5. Assess feeding and consider more frequent follow-up. By 2 weeks at the latest, the baby should have regained its birth weight. Infants lose more weight in the first postpartum days when labor meds are used, but perhaps not at a baby-friendly hospital. When more intrapartum fluids have been given, when there was no labor prior to cesarean. However, supplementation rates for weight loss decreased with routine use of 24-hour weight and did not increase up toward effects during the hospital stay. What do we know about breastfed babies who become dangerously undernourished? A report by Cooper and colleagues identified a significant increase in the incidence of malnutrition and hypernatremia in breastfed infants. 5 sentinel cases in Ohio began a chart review of the prior 4 years. Chart review babies were 23% below birth weight on average on readmission and showed clinical signs of dehydration and hypernatremia. The babies were not discharged early, nursing Q 3 to 4 or 4 to 6 hours, scheduled both breasts 5 to 10 minutes aside. They were sleepy. The researchers concluded the class was inadequate. Hold on for a second. Also, there was inadequate postpartum follow-up in the community. How do you know about breastfeeding adequacy in the early weeks? Fewer than 4 soiled diapers on day 4 when used in conjunction with delayed onset of lactation may indicate breastfeeding inadequacy. 4 on 4 and each day after. Cooper findings continue. Babies were not identified before 10% weight loss. A contented, sleepy baby is not a well-fed baby. Calorically deprived babies are sleepy. Update. Breastfeeding-associated hypernatremia. Almost 2% of 3,718 consecutive term and near-term neonates were hospitalized in Pittsburgh for BAH. A median weight loss was 13.7%. Hypernatremia is a common complication of an inadequate milk transfer during breastfeeding in the U.S. a completely preventable complication that seems to be relatively common. Weight loss difference 1.6% in healthy infants, 6.2% in hypernatremic admitted infants. Frequency of breastfeeding per day 10.2 for healthy infants, 7.6 in the NHD admitted infants. How has the AAP responded? Ensure formal evaluation and documentation of breastfeeding by trained caregivers, including position, latch, milk transfer examination, at least for each nursing shift. AAP continues. All breastfeeding newborn infants should be seen by a pediatrician at 3 to 5 days of age, which is within 48 to 72 hours after discharge from the hospital. Evaluate hydration, elimination patterns. Evaluate body weight gain, body weight loss no more than 7% from birth and no further weight loss by day 5. Assess feeding and consider more frequent follow-up. Discuss maternal infant issues. Observe feeding. Does it make a difference if the mother is malnourished? There were no differences in growth of the babies between the supplemented and unsupplemented mother groups, but infants of undernourished mothers may not receive the extra care and stimulation needed, and the duration of exclusive breastfeeding was higher in the increased energy group. Myths and illusions abound about breastfeeding. Size of the breast relates to the amount of milk. The proportion of glandular and fat tissue and the number and size of the ducts are not related to milk production. For healthcare providers, perceptions of who will have difficulty with breastfeeding may be related to breast size. Not getting enough fluids. There is not enough evidence to support increasing fluid intake beyond what breastfeeding mothers are likely to require to meet their physiologic needs. Maternal exercise when breastfeeding was not related to infant weight gain or growth. Rest is not associated with increased milk production. Fatigue may be tiredness, but may also be a symptom of an underlying medical problem that could affect milk supply. Increased worry or stress does not seem to directly diminish milk supply in humans, but worry or stress may alter behavior, which may alter supply. Breastfeeding mothers may perceive less stress. Compared to formula feeding mothers, breastfeeding mothers had more positive moods, reported more positive events, perceived less stress. Stress plus male hormones equals flight or fight. Stress plus oxytocin plus female hormones equals tend and befriend. Myth: it's about types or amounts of foods eating during lactation. Humans have breastfed and are breastfeeding under conditions we can't even imagine. This is possible because lactation has a lower energy cost for humans compared to other mammals. Number of kcals a day for lactation is much less than was previously believed. The body adapts with physiological mechanisms in favor of lactation in humans. When the infant suckles from the breast, there is an outpouring of 19 different gastrointestinal hormones in both the mother and the infant, including cholecystokinin, which cycles to the kidneys, and gastrin, which stimulates growth in the baby's and mother's villi, increasing surface area and absorption of calories with each feeding. Our ideas of the energy need of human lactation come mostly from where the caloric need is highest: domesticated dairy animals. How is it possible for humans to make milk with such a small amount of energy expenditure? Maternal plasma prolactin concentration generally increases under conditions of negative energy balance, which may serve to protect lactation. Changes in maternal processes can spare energy. This may account for a third to a half of the total cost of milk synthesis. Together with the low cost of human lactation and large fat preserves from pregnancy, may account for human ability to breastfeed our infants under nutritional conditions which are often far from ideal. So how do we assure an adequate milk supply? Universal understanding of how breastfeeding works. Early initiation and adequate breastfeeding, 10 to 12 times daily. I highlighted that. Appropriate breastfeeding assessment, improved and early breastfeeding support to decrease lactastrophes. Appropriate HCP and LCP follow-up in the postpartum. See reasons to refer in the appendix. Admitting that there's no magic bullet. And that is the end of the 1B handout. Keep in mind there are 9 handouts that correspond with all of the videos, and these handouts are not a substitute for actually reviewing the videos. You will need to review them, and they are roughly between 4 and 5 hours each. Each section is about 4 to 5 hours. So be prepared to have that time to watch those videos. These handouts are just a supplement to those videos and a supplement to your notes. Thanks for watching.